Good afternoon and welcome to the Women and Equalities Select Committee, and welcome to all the guests here as well as our witnesses. Thank you very much. Today we'll be looking at women's reproductive health conditions following a series of evidence sessions held by the previous committee in the last session. Today we'll be hearing from two expert witnesses, and I'm very grateful that you were able to join us today. Dame Lesley Regan, the Women's Health Ambassador for England, and Dr. Sue Mann, NHS National Clinical Director for Women's Health. Thank you both for coming. I'm going to hand over to Kira for the first section.
Thank you, Chair, and thank you very much, Dr. Mann and Dame Lesley, for your time today. Really appreciate it. I'd like to start just by asking something that I'm sure you've both heard a lot of, and I've heard a lot of from friends and family as well, but women have reported having their symptoms dismissed and normalised by GPs all too often. I just wanted to know what's being done to address these concerns.
I think that was a major finding of the Women's Health Strategy, which, as you know, was responded to by over 100,000 people in the country, and that I believe the figure was 82% of women felt that they had been dismissed or ignored, or that they hadn't been taken seriously. And the Reproductive Health Survey, which the London School of Hygiene and Tropical Medicine launched last year, has found similar concerns. And I think one of the factors that we've both been working on is trying to ensure that the things that women have commonly during their reproductive and their post-reproductive life become part of everyday chat. So my example is always, there's nothing else that happens to human beings quite so commonly as 12 periods a year for 40 years of their lives. So if every year they have 12 days when they can't function or they can't go to school, this is a massive disability. So rather than say, oh, it's just a period, forget about it because it's embarrassing to talk about, I'd like everyone to be talking about it. And I think that's the way that we would be able to get our healthcare professionals to understand what a massive impact it has if they are disabling, and just understanding what normal is. And people often say, well, what should I say? And I said, well, are you still having periods? And then if the answer is yes, because you have to be a little bit sensitive to people who may be menopausal, then you say, well, do they ever stop you getting on with your life? And if the answer is yes, that's not normal, you need some help. I think if everyone adopted that, we wouldn't have an enormous number of the problems that we do have.
And that's, I would really agree with all that. And I think that, it's a shocking statistic that we've seen. And it's really important that this is known about. So I think there's sort of three aspects, really. Listening to women, really important. What are we going to do about it? And then how will we know that we've made a difference? And I think, thinking about how we listen to women. So we've asked them for evidence. So that's been really, really useful. How do we continue to do that well? So I think there's some things that need to happen nationally, which we're working together on. So how do we bring women to the sort of national decision-making board? So how can we get sort of proper representation for women who have lived experience? And that's complicated. So we've got already some really good groups out there, and we can call on those, can't we? So we've got the Health Collective, which is a wellbeing of women group who we've spoken to quite a lot. There's also the RCOG, have got Women's Network, so we'll really be important to be talking to them. And we're just really trying to think about how do we get the voices of women who don't often get heard. So we're making equalities really, really central to what we're doing. So making sure that really that sort of shapes strategy. So I think if you get it right for the women who are least well heard, you get it right for everybody. So, but of course we can't have a homogenous response. So one person's experience is different from the next, and that's really complicated. So having good representation at decision-making level is important. But also then you have to go more locally because populations really vary. So what's true in the centre of London where we are is going to be very different in rural Devon, for example. So trying to do a one-size-fits-all is not going to be effective. So thinking about that and making sure that local areas are equipped to speak to women in their patch. So we want to support local areas to reach out to those women and really put equalities within the plans that they make. So making sure that it threads into ICB plans, properly. They already have a requirement to respond to inequalities, and really trying to help to put some women's health issues into that, I think, would be really good. Then there's a whole lot of things to do in between to make sure that we sort of polish up what women actually get, which I'm sure we'll start covering in a bit. And then sort of coming back and thinking, have we done okay? So, how do we listen to women properly? And the reproductive health survey was really useful for that. So thinking about what else we can run to keep an eye on what's happening.
Thank you.
Thank you. And just on that last point that you mentioned, do you think, in your experiences, that intersectional differences are sort of sufficiently understood by medical professionals? So, for example, how somebody's ethnicity or culture might affect their reproductive health?
So I think we've heard from women that it's not. And I think that's important to listen to. I think that obviously the differences aren't all the same. So intersectionalities are really important, and often ethnicity links with deprivation, for example. So really trying to put those things together is important. And also not saying that the experience of one group is the same as the experience of the next group. So I think that we need to get smarter as clinicians at sort of not making assumptions. And I think there's a lot of sort of unconscious bias going on, and there's a lot of training that is needed in the clinical workforce to make sure that that those things are at least recognised and the right questions are asked, because we probably won't know. I think we have to assume we don't know.
I think there's quite a few examples we could give you of where a particular faith group or a particular community doesn't have actual words to describe something. So there are some South Asian countries in which there is no word for breast, and in others where the word menopause just does not exist. So it's very difficult then to understand that if you've not been used to it. So that's one of the reasons why 18 months ago we set up this Women's Health Collective based at Wellbeing of Women, which is the charity Women's Health charity I chair. And I set it up with Nigat Arif, the Muslim GP, and the proposal was that we would invite a representative from every disadvantaged or marginalised group that we could identify. So as well as an ethnicity and religious groups, we've also got neurodiversity, physical disabilities, hearing or sensory disabilities as well. And I have to say I've learnt an enormous amount from listening to them. And the first thing I would say before you can do anything about providing better help or better care and becoming, as you say, more aware as a white, Caucasian, well-educated woman of what these people are needing and what they want, as opposed to what people that look like me think or have been taught that they need or want. And I think, first of all, in order to have that conversation, there's been a lot of work done in building up trust. And so 18 months down the line, I think we've now got a group who are very responsive when I ask them for their feedback on things, because they know I'm not just getting them to tick a box, but I actually want to know what they think.
That's great. That's really good to hear. Thank you so much, and for sharing some of the work that you've been doing on this issue as well. I also want to just expand a little bit more and just find out sort of what work is being done to prevent some of the racial biases we've sort of seen around women's pain thresholds in particular.
Well, I just don't understand how that has come about, really, and it's not that I'm naive or I've got my head in the sand. I just find it so extraordinary that if someone's in pain, particularly when they're in labour, that you don't do everything you possibly can to alleviate it. There's also an issue about procedures like hysteroscopies and insertions of Mirena devices and things like that in clinics. And I think it's been a bit of a sort of a catch-22, really, because I can remember 15, 20 years ago, we were all being told it's a really bad thing to give a woman a light general anaesthetic to do a hysteroscopy or insert a coil, particularly if she's a nulliparous woman, i.e. she's never been pregnant, so the cervix is never dilated, it's likely to be more difficult, or perhaps if she's very overweight, or perhaps if she's got uterine fibroids, which have changed the shape of the uterine cavity, so it's more difficult. So we were all encouraged to do this in outpatients, and now, of course, we've got people who feel that they've been really, really quite physically abused by the pain they've experienced during a procedure. And I would say that it's not necessary to have a painful outpatient procedure if you use enough local anaesthetic and you'll actually actually talk the woman through it and explain what you're doing at every stage along the pathway.
And I think it is really important to think pathways, because I think those differences happen all the way along. So when you start thinking about how do women get their information about the procedures they're going to have. So, for example, there's some really good information on the NHS website about procedures, but just making sure that the right people have access to it and that people get their information early and understand what choices they have. Now, of course, if it's that information isn't accessible. So, we've heard a lot about particularly the issues for women who don't speak English, for example. How are we going to cater to them? And again, that will be down to really understanding local population, so making sure that local areas are knowing their local population so that they can actually make sure that they've got the resources in the right languages. That's a sort of ICB level, but just making sure that we support them to do that kind of work is really, really essential. And then, moving on to the next phase of the thing about, when someone actually comes into care, how can they have a meaningful conversation that doesn't inject any biases into it? That's a very difficult thing to ask, because we're all biased on some level. And I think just trying to have a proper shared decision making, so that, because there are a range of options that are open for procedures. And just to say, the majority of people don't necessarily find them painful, and if we select people appropriately, so that with them to have the right level of sort of support in terms of preventing pain, then hopefully fewer people will experience pain. But it's really important to give people choice and make sure that they have the thing that's right for them, and they won't know that unless you have a proper discussion. And then the system needs to be ready to do that. So we've got, so when you think about, for example, IUD insertion. So we're doing a lot of work, and I'm sure we'll come on to women's health hubs, but we're really doing a lot of work to try and widen access to things like IUD insertion, have a really skilled workforce. And that helps with pain, but it also helps with that kind of selection. And then things like the community diagnostic centres, which have been opened up, which are diagnostic centres in the community, are also well placed to do things like diagnostic hysteroscopy ultimately, if that's what the local area sort of decides. So having the places set up well because not everybody who does these procedures is going to have the full range of local anaesthetic available, so it's just making sure that people go appropriately.
I think also making women aware of what they can ask for and they should ask for, because I don't think there'd be many men who would go to see a urologist and have a cystoscopy without anaesthetic. So, and I think we just got to get we just got to get the narrative a little bit different, that actually you don't need to have this discomfort and you need to explain. And I think one of the other things, I'm sure Sue will agree, is that one of the most useful things you can do if you're doing something to a woman in a gynecological outpatient is tell her, if you're uncomfortable, you want me to stop, just tell me immediately. And just that very knowledge that she's got some control over the situation actually usually calms people down quite considerably. But at the end of the day, it's not a pleasant thing to do. I don't like having my coil changed that much either.
Thank you very much. Before we move on, I just wanted to dig down on a very specific point around ethnicity and culture and women's pain. Big fan of Nig Atsworth as well. If anybody is watching and doesn't know Nigat, please follow her on social media. She is a wealth of knowledge. But I wanted to talk about particularly trust. Dame Lesley, you talked about trust, and that's really important, particularly when it comes to FGM. And it is something that I am seeing increasingly in my inbox, and I know is happening still in the UK, as well as women being taken to other countries for that to happen. And the trust element is so important, and I wondered how it is that you are able to gain that trust, particularly with women that are of child-rearing age, of 25 to 32, who have been subjected to FGM, usually by a family member as well.
Well, I remember when I was a very junior consultant and I first went to St Mary's, a part of the Imperial Group, I was the only woman consultant, obstetrician and gynaecologist, which in itself is a bit of an oxymoron, isn't it, these days? But the reality was I couldn't understand why I kept seeing all these young women from the East and from the Middle East who were coming to see me, who had never been able to disclose before that they had had FGM. And the very striking thing, come back to your point about trust, was it wasn't the physical act that distressed them so much, and it wasn't even the fact that this was part of a male culture imposition. It was the fact that their mum or their auntie or their big sister had been complicit in this. And they told me, and I've got no reason to disbelieve them, that that was the thing that haunted them most, and that they couldn't understand why another woman would do this willingly to somebody. And so I think that, recognising that I don't understand all of the cultural mores, if you like, and asking people to please help and inform me with what I need to know about what they feel about something or where they're coming from, so that I can appreciate their position, I think is most of the solution to this.
And at a more kind of patient-facing level, Dr. Mann, what do you think needs to be done? Is there more work that needs to be done, particularly in this area? Because we heard a lot about FGM, say, 5-10 years ago, and it seems that, people seem to stop talking about it quite so much. And actually, from what I'm seeing, from the reflections from communities, actually the problem is very much still there. And it's a problem when they disclose, even if they speak to their GP. Even one woman was told that it was just cosmetic work and to see a plastic surgeon. So I'm wondering if there is more work that needs to be done on that level.
Absolutely, and I think the trust has been eroded, and I think part of it is understanding what we need to do from the communities that we're serving and working closely with voluntary sector to know what that might be. But I think we have a responsibility as clinicians as well when we see people in clinic. So often we'll do a gynecological examination, and it is the one opportunity to actually recognise FGM and then initiate a conversation. So I think we have a sort of opportunistic kind of duty to do that. And women experience awful things apart from the trauma of the actual procedure. They have urinary problems, they have sexual difficulties, all sorts of pain, infections. So to give people the opportunity to have that conversation and then decide for themselves, it's a choice. And I've seen quite a few people who've said, no, thank you, I'm absolutely fine. And I might look and examine them and think, gosh, that surprises me. But I think even having that first conversation and then following it up, because after that we have got specialist clinics, but if people aren't using them, then we're not getting it right. So I think that's really our duty.
Thank you. That leads us on to Rachel.
Yes, I think you've touched on some of the areas that I was going to ask about in respect of painful procedures. And women have described feeling pressurised into enduring severe pain during those routine procedures like hysteroscopy, and being ignored or belittled when they can't endure it. Now that may be because of lack of availability of anaesthetists on the day that they're in the outpatients department. But what's being done to challenge those behaviours of feeling belittled and so on?
Well, I think by talking to women, by demonstrating that we have got a women's health strategy now, we've got not just an ambassador, we've now got a national clinical director who are leading it and who have a bit of expertise in this field. That's not a very satisfactory answer to what can we do. A lot of this is about education and, ensuring... I find it strange that you have to educate a nurse or a doctor or any form of healthcare professional to recognise that they must be sympathetic about pain, because I think that's something that's probably inherent to your training if you go into the health world. But obviously we do, because they are feeling belittled. But a lot of it, I think, is talking people through it and explaining to them that they are in control, and if they find it too overwhelming, that you will stop.
You want to add anything to that, Dr. Mann?
Yes, and I agree that there is a real sort of effect of having someone who is confident and professional at doing the procedure to help someone through the procedure, but that no one should ever be pressurised into enduring something that's painful without, as Lesley says, stopping. But also, the idea that people are pressurised is very uncomfortable, I think. So thinking about a couple of things. So obviously we work closely with professional organisations. So the RCOG, the Faculty of Sexual and Reproductive Health have produced a guideline on procedural pain. So really important, it's one thing having a guideline, but the next thing is making sure that people adhere to it. And sometimes difficulty adhering to a guideline is about what is available in the system to provide. So we need to kind of make sure that we have that tiered system where if you are, for example, someone who's had a lot of vaginal deliveries, you've had procedures before, you're likely to tolerate it very well. That could be done in a relatively low-key setting, but or as an outpatient, but looking further towards where could you get the general anaesthetic if you need it, or local anaesthetic if you need it. So I think understanding that to begin with, and making sure that the procedure starts in a place where you're not going to get that to happen. But you can always stop a procedure, and that's a professional education thing about doing that.
I mean, quite often, though, women begin the diagnostic process for reproductive health issues when they're girls. And they may have never had penetrative sex, and the idea of a painful, invasive procedure can be really intimidating. How do we make sure that young women and girls and victims of domestic violence, rape, and lesbians who are not used to having penetrative sex are sort of, able to be looked after in that sort of setting? Because I think most of us appreciate that as women we're able to have a voice and say that we can stop these things, but I think if you're in one of those groups it's so much more difficult. So what do you think we can be doing more to
the very practical point is that if I was a paediatrician, which I'm not, and I was ordering some blood tests to be performed on you, for example, Samantha, I would, in addition to ordering a blood test, I would give you a prescription for some Emla cream to put on your arm so that it anaesthetised the arm before you had the needle put in. So, if you're going to send somebody who is a young girl and you want to make sure that in the future she doesn't fear going to see a gynaecologist and that she is going to turn up for her cervical smear and she's going to use the very best form of long-acting reversible contraception that will suit her, so that she only gets pregnant if and when and with whom and how many times she wants to be, then why not just order the blood test and also give her prescription for some Instilogel? I think it costs £4.50 or £5, and you give them a prescription and then they take it along with them. I mean, they're just practical things that I've learnt on the hoof. But you're right in that nobody sort of puts that into the pathway, and that's what we've got to work out, and that's what we want to try and establish in these women's health hubs that we're both championing. That we know we want very, very senior people to be doing the triage of the referrals, so that they've got that added layer of expertise and knowledge to think, right, well, Rachel will probably be okay there, but then Catherine wouldn't be because she's got that particular history, or she's had that problem in the past, or her children were delivered by caesarean section or whatever.
Do you think that's something that can be put into guidelines?
Yes, I think it can be. And we also need to work with the curricula, and we need to get, the training programmes, both at the RCGP, at the RCOG, the Royal College of Midwives, all to understand that sort of personalised based care, which I don't think is difficult, but it seems that because there's been a void of it, apparently, with all the people that have complained differently, that it becomes a part of everyday work.
And I think, we really need to think carefully about trauma-informed principles guiding what we do in reproductive health. And, that should become more universal, and we often think about it in particular settings, but actually it needs to shape everything that we do. And, we do see people, so the young women, I would hope mostly they don't have sort of internal examinations without a very, very good reason to do that. So people who have never been sexually active, that is a really, that should be standard practice, that in order to actually examine someone internally, then that there should be a very good reason and a very big conversation about how that might happen. But there's plenty of other women as well for whom examination is really, really difficult. And it may or may not be because they've had previous sexual trauma. It might be because they're postmenopausal and it's very uncomfortable. There's all sorts of reasons. And so, you know, it goes back to the same principles about, you know, good consultation skills, but also having the facilities. I think we're going to keep mentioning hubs, aren't we? But, you know, there is a place to say this needs to be done in a setting where there's someone who's more familiar, who's very familiar with doing sort of intimate examinations, so they're very expert, and thinking about what preparation might be needed, and also just making sure that we only do the things that are absolutely necessary. And patient choice comes at the front of that, because actually all women can choose, you know, given the right information. So that's about the shared decision making. You know, this is the consequences of not, and this is the consequences of having your examination, and would you like it or not? So I think that's important too.
Thank you. Moving on to a slightly different topic now, about different reproductive health conditions. Do you think there's sufficient guidance on the different health conditions? For example, should there be a NICE guideline for each reproductive health condition? And that's to you, Dr. Mann.
Yes, so we're really glad that NICE now have a sort of suite of reproductive health guidelines, and we've had two new guidelines, one updated and one published in the last week, actually. So menopause one and an endometriosis update. So we really welcome that. Of course, NICE guidance is always useful in terms of shaping and setting standards for what care gets provided in the, and obviously it is only guidance, but actually it does really drive what should happen and how we set standards for delivery of care. So when you say for every condition, I mean, Lesley and I talk a lot about, you know, conditions being a continuum. So you have endometriosis is a good example. You have endometriosis, but then you have pain. So you have a whole continuum. What conditions actually need a guideline? We need to look where the gaps are, and NICE, and we work very closely with NICE to start sort of thinking about how to shape that, and then how to provide decision-making tools alongside those. So I think it's difficult to say should there be on everything. I think there should be on the conditions where we don't have enough guidance to shape good care. And that's an ongoing conversation about where are the gaps, what do we need most urgently, and then supporting the kind of development and the delivery of that.
Do you think it matters that these guidelines are being produced, in effect, by different organisations? Or do you think that sort of helps to inform them because they're being developed by groups and organisations that know that specific condition better?
Well, I think NICE have done a lot of work recently on collaborating and utilising other people. So, for example, they've been asked to produce a guideline on polycystic ovarian syndrome. And I know that Jonathan Benja, who's heading up this reproductive health suite of women's health issues, felt that the Australian one, which had been published, I think, last year or 18 months ago, was very, very comprehensive. So why didn't they refer to that? And I would encourage that, because the more collaboration we get, the more uniform the understanding will be. And it means that we can also then have resource to tackle other topics that haven't got guidelines. So I think it's the bane of both of our lives that, you know, somebody else reinvents the wheel and calls it something different. And we just need to collaborate a lot more.
Thank you.
Thank you
very much.
Thank you, Rachel. I just wanted to come back on the last 2 points that both of you made. You talked about gaps in guidelines and illnesses or conditions that don't have guidelines. Which are the ones that don't have guidelines which you believe should be a priority?
Well, we've done quite a lot of work in the last 2 years on improving the NHS website, and now there are 100 topics grouped together under a women's health section. And it is true, because I think everybody knows that Nagamun Chetty asked me about this on BBC Radio 5 Live. Why is there nothing about adenomyosis? Yes. And my commitment to her was I will get adenomyosis on the map, and it was done within 2 months. So, but, you know, it takes a lot of pushing, and there are all sorts of competing pressures on NHS Digital's time. But we've managed to do that, and I think that although, as I sometimes say to my patients, I'm suggesting they look on the website. So it's not a very sort of dramatic website, is it? It's very blue and it's very monochrome. It has to be done a certain way and it's got to be alphabetical order. But what they have got now are some really, really helpful links to videos, to animations, and all sorts of other ethnically diverse, if you like, ramifications of it. So I think it's a lot more interactive. Well, no, it's not more. The website isn't more interactive, but it really does signpost. You're not just told go off and find something. You can press on the link and get there.
Thank you, Tamara.
Yeah, so I think often the guidance is out there. The point of having it at NICE is that it becomes very, very accessible to people. So it is always good to get NICE guidance to shape what we do. And much like Lesley's saying about adenomyosis, you know, we need to listen to what isn't there. And polycystic ovarian syndrome is another one that's sort of coming through the pipeline in terms of what do we do. And yes, you know, we've already got an international guideline that will be, and the authors of that are going to be very much sort of instrumental in the NICE guidance, as Lesley pointed to. So we hear and then we work with NICE to try and help prioritise the topics that come through, but there's a lot of competing pressures, of course.
Thank you. Catherine.
Thank you. Yeah, my question is, I'm a Welsh MP, which I better say that's the kind of context for my question, because I understand that NICE guidelines officially only cover England, but then the decisions on how they apply to Wales are made by the devolved governments, but it seems that they could sometimes cover Wales as well. Therefore, how does, in practice, how does that work? I hope that's okay, Chair, to ask that question. I just think it's important that people in Wales know how this works for them.
Well, I think I'd respond by saying, well, it's on a website. You know, you can just go and get it. And so we need to ensure that the signposting, we provide women with the signposting that they need to be able to access the information they need, and also the healthcare professionals that are looking after them.
And I'd also say in terms of topics, I mean, we do work closely with, we both know the leaders in Scotland and Wales and Northern Ireland, so we are in constant conversation, and often the health problems are pretty similar, and the need for guidelines are pretty similar. So I would say that would influence the kind of direction of travel as well, but obviously not directly because, well, I'm in NHS England and
yeah, I get that. Thank you.
Thank you. Just wanted to ask a follow-up question on that. As somebody who's just been recently diagnosed with adenomyosis, it took a while. The information that you've said is out there, I would say, is even for somebody as well briefed as myself, not always the most easily accessible. We don't always use websites. We particularly don't tend to use websites that are not accessible or interactive in some ways. I was wondering how you measure the success of the guidelines in terms of how often and how well practitioners are using them, but also how patients are accessing them as well.
Well, wearing my Wellbeing of Women charity hat, we've got a website which is very interactive, and I run a monthly webinar on stigmatised or difficult topics or things that people don't normally discuss over dinner, and they are extremely well attended. And I can talk to the data people there, and they can tell you about the clicks that go through and whatever. And I'm sure that anyone who's running the NICE website could also provide that information. But I think it's much more about raising public awareness, and there have been several campaigns. There was one that the Department of Health ran earlier this year, about don't suffer in silence with period problems, and Wellbeing of Women have just won a prize actually in the third sector for their Just a Period campaign, which is a film campaign featuring women from every very, very varied ethnic minorities, and talking about their experiences and how encouraging women not to have pain or heavy bleeding that they can't manage. It comes back to my point earlier about, if your period stops you getting on with the rest of your life, then that's not normal and you need help. And, when we talk about the fact that women are waiting 7 or 8 years to be diagnosed with adenomyosis and endometriosis, if every healthcare professional you went to had asked you about your periods, you wouldn't have developed Certainly endometriosis, adenomyosis, I think is a little bit more complex in the way it's formed, but you wouldn't have developed endometriosis. You don't wake up one morning saying, I've got endometriosis or I've got polycystic ovaries. It's a progression. And so if we prioritise the common things that women experience from a very early age in their reproductive lives, then I think we will massively reduce the morbidity and the suffering that they experience.
Thank you. Dr. Mann, did you have anything to add, or we can move on to the next question?
I also think it's just important to sort of think about where people get their information from, and I'm sort of plugging the NHS website, but I actually do think it's very good for these kind of conditions, and there is a page on adenomyosis, and that is monitored in terms of clicks. But the proof is in the pudding, isn't it, in terms of did people feel that they got the information they needed, and we need to keep asking people whether they're informed, whether they know what to do, and actually sort of I guess the basis of any information sort of strategy is people feeling they've got enough information to know when they need to do something about it, and then to understand what they've been told. So if we're not getting that right, we need to listen to that and hear it.
Thank you both. David, moving on to medical training.
Thank you, Chair, and thank you both for coming in today. I guess this is really to you initially, Dr. Mann. I know from experience that with a family member, the diagnosis that's similar to Sarah has taken a very, very long time to get to a diagnosis of endometriosis. And then obviously we've heard similar concerns around the test procedures and then the actual treatment, with people often just saying, okay, the treatment is you're going to go onto the contraceptive pill or whatever it might be. Do you think the current training for medical professionals is up to standard? Is it sufficient to diagnose and to move on to the treatment for individuals once they are diagnosed?
Yes, so I'm sorry to hear about your family member, because I think that is the experience of a lot of people, and that's had a lot of it's come up our agenda, and that's really, really important to know and to understand. And I think a lot of people with a diagnosis of endometriosis have waited a very, very long time. So just sort of broadly, and that's been highlighted in the recent NCPOD report, but also really thinking that the NICE guideline is really the sort of updating it is really trying to shift towards improving earlier diagnosis. So if I could sort of take it back a bit, because I think just talking about training is really, really important, but I think it needs to happen at every stage. So first of all, we talked about women being taken seriously. Now, women have awful period pains very often that keeps them off work, and they often come to me and will say, well, they're just my periods, it's normal, I don't go to school or I don't go to work for a couple of days every month. And I have to say, no, that's not normal. That's not as it should be. So that's the first thing, is really trying to sort of help empower women themselves to not feel like they're being a bother if they come and they say that they're having pain. The second thing is to say that we need to kind of treat every person with pain the same to start with, and a diagnosis of endometriosis is a process. So often the way that we treat pain for periods is the same as the way that we treat endometriosis. The difference is that if it doesn't get better, then we need to go into the next stage. So I think that's really, really important in getting people on the front line to be good at listening to people's complaints of pain and taking the early steps. So sometimes that's just good pain relief, but actual treatment for endometriosis is, first line tends to be hormonal. Now, we recognise that there's a lot of, in the community, there's been a lot of sort of worry about hormones. People are really not, whatever we say, there are some people who do not want to use hormones, and rather than say, well, that's the best thing for you, we need to get good at listening to that and going, okay, well, that would be the best treatment at this stage for you, but of course it is also your choice. So that's those sort of initial conversations in a sympathetic way to say, here's a range of treatments, and these are the kind of things that might happen, and these are the things that won't, and what do you want to do? Making sure that people get early diagnostic tests. So we know that ultrasound is really important early on. So we want to kind of make sure that people know that, and that again is in the guidance, so people should be following them. So that's sort of at the general level when people come to their first port of call. And we, the training for that. So there's lots of, so we're talking about really sort of primary care. So there's lots of resources around that. the RCGP have some very good resources. They have a library of women's health resources that can be used, that are regularly updated. That's Primary Care Women's Health Forum. So there's a lot of work going on. And we know there's still variation. GPs have to do an awful lot of different things. And understandably, some of them are more expert in women's health than others, and the others are maybe more expert in something different. So it means that women will get some variable experience. But what we want to make sure is that if you don't get help at the first port of call, that it doesn't just stay. So I think that we'll reduce these 10-year lags to diagnosis if we just make sure that "are you getting better" question happens, and or "I can't help you, so I've got somewhere else to refer you." And then the next stage would be that intermediate layer of care, hopefully in the community with slightly more specialisation, and then potentially on to specialist services. And we know that NHS England are developing a service spec for severe endometriosis to make sure that that end of things gets also managed much better. So it's diagnosis, effective treatment, and then being linked in with pain specialists and those also those other members of the team that are important. I think just the last thing to say is that we know endometriosis is important for fertility. So when we see women, younger women who do have an intention to become pregnant at some point in their life, we need to really sort of think about making sure that we act as quickly as we can.
Okay, thank you. Perhaps one for both of you. So what needs to be done to improve current practitioners' access to professional development on women's reproductive health conditions? So is there more that can be done, and what can we do to improve their access?
Well, I think prioritising in training, both in medical training and nursing training, the importance of 51% of the population, and the fact that so many of the problems that women experience and have had a bad deal, if you like, in the past, are very common day-to-day issues, and we've got to make sure that they're catered for. I often say, when I'm talking to women, most of the occasions when women go to see healthcare professionals, they're not sick. They're trying to do something to maintain their health or prevent a problem happening later. And I think we've got to ensure that all the clinicians we train appreciate how common these things are. I've given you several examples, I won't repeat myself, but it's a large percentage of the population, isn't it, 51%? And there's an inevitability, for example, about becoming menopausal if you've had periods. So, and 400,000 women enter the menopause each year. So instead of this being a great big surprise and us having to have a celebrity campaign over the last 2 to 3 years to make this something that's talked about, we need to recognise that so much of life is unpredictable. But if you can predict things happening, well, then let's get upstream and make sure we've catered for them in good time. And so I would say period problems, contraception, things like that, menopause, women shouldn't have to go to secondary care to a hospital in the first instance to have those sorted out. It should be a very routine thing close to home in the neighbourhood. And then, if, as Sue has said, if when the follow-up, are you feeling better? Are you going back to work? Or can you go to school now? If the answer's no, then that's when you need to refer into specialist services.
I guess when we look at the diagnostic figures and how long it's taking women to get diagnosed and how many times they have to visit a GP before somebody eventually says, right, okay, we've got to now start doing something about this. Can we look at a way to maybe start incentivising medical practitioners to take up training? Because there's a gap here, isn't there, across the industry, and we've got to do something to close that gap.
One of the things that I think Sue and I feel very passionate about is establishing these women's health hubs and actually ramping them up or scaling them up. Not just because they provide good care by people who are interested in women's health and therefore will invariably, I think, do a better job if it's something that you find interesting and rewarding, but also because there are fantastic training opportunities. So I'd like the GPs who haven't done much obstetrics and gynecology during their training, and you don't have to, I believe now, have done an O&G rotation when you're doing your GP training course. So we could rotate them through, and we could rotate our trainees through it. It'd be fantastic because, I have young trainees who perhaps a year or 2 years off becoming a consultant, and they're with me in an operating theatre, and they don't know what something is because they haven't done those common or garden things. They may be very specialist in others, but they may have very specialised skills, but I think sometimes we forget, and we need to keep reminding people about what's common needs to be sorted out easily and quickly close to home.
Dr. Mann, did you have any thoughts?
Yes, and I think, it's important to make sure that you've got the right skill mix. So, I would like to see women's health hubs as sort of looking after a population and saying, well, we need the right people to provide care for that population. So there'll be some people who will just be able to make an initial diagnosis and make the right diagnostic tests and make a sensible referral. And then, as Lesley was talking about, the sort of more specialised tier who want to do more. And I've got some really excellent GPs who work with me in the hub where I work. And it's a really important career development pathway for some. I think it improves retention, it diversifies portfolios. So, but also, as Lesley was saying, that we can start to rotate people through so they get some exposure, but they might just go back to general practice, which is also really important because we still have to have that general layer. But we do need to find ways to help people to get and we are looking into that. So we're looking at what kind of workforce, what skills are needed, and thinking about that, being aligned to obviously the 10-year plan, because there will be a workforce element to that. So thinking about how can we ensure that we've got training right in women's health to provide all the tiers. It's not just doctors as well. It's a multi-professional workforce. So we need pelvic physios, for example. So, thinking about who are those people and then have we got the right skills there? Probably we've got a lot of the things that are needed for training. We just need to pull them all together.
Thank you, David. Just quickly, Catherine.
Quick follow-up. I just wanted to check that I'd heard right, that people training to be a GP don't have to do obs and gynae rotation.
No, they don't. When they choose their rotations in their VTS scheme, I believe that you don't have to do obs and gynae now, whereas it used to be mandatory.
Because that seems absolutely mad to me, and at the very least, in my opinion, where I'm in a very rural constituency in Monmouthshire, you need to have at least one person in your GP's practice. And in fact, when I was CEO of a women's equality charity before I came here, we were campaigning very strongly for across Wales to have at least one, and across the UK, one specialist on women's gynecological conditions in each GP's practice. And I've in fact got a group of 80-plus-year-old women who cannot get their pessary changed, have been told they can't have their pessary changed, and that's about a prolapse issue, at the local surgery. A couple of them can't drive. They've been told they're going to have to go to a hospital half an hour away.
Well, on Monday morning,
there's no public
on Monday morning, I was in the operating theatre and I was looking out of the window and I saw an elderly lady come out of an ambulance accompanied by 2 ambulance drivers and a carer. And then they went in, and I'm thinking to myself, I bet because he went into the gynecology outpatients, I bet she's gone to have a pessary changed. So can you imagine, and quite often I've seen as well women say, elderly women saying, well, this is the 3rd time I've been, and the ambulance was late, so I missed the appointment last time, etc. I mean, the resource that is wasted on something that could be done in 5 minutes in their own home. And as long as they haven't got arthritis, and they're not too squeamish about it, we could teach those women how to change their own pessary. It's not difficult.
Thank you. You've both alluded to the need for women's hubs. I just wanted to ask some questions about that. Do you think that the funding has been effective for women's hubs? And are there enough hubs across the country to ensure all women and girls are having access to the sorts of services that you've just talked about?
No, and I don't think that anyone's pretending that there are enough yet. I mean, it was a pilot, and it was a pilot that it was decided the 25 million would be split up between the 42 ICBs equally, not because it covered the population in a fair way, but that would give every ICB an opportunity to set up a pilot, and we wouldn't then be effectively endorsing the ones that were performing well to do even better and the ones that were performing poorly to do even worse. And I'm an incurable optimist, which is fortunate really, but I do think that the enthusiasm that we've met in the various different, I've visited all the ICBs, has been absolutely enormous. And individuals telling me that they've stopped doing something or other and they've decided to go and work in this. And as Sue mentioned earlier, it's not just about providing the good care, but we have a big problem with our workforce in the NHS. We're the largest employer of people in Europe, and 80% of them are women. And so if a lot of those women are having period problems themselves or menopause problems, and we're not actually sorting them out easily, getting them back to work, then we've got a workforce problem. And the reward, I think, from working in a service where you feel that you're doing a good job and you're not having to say, no, you can't have that because I'm not commissioned to do your smear, or no, you can't have that because I'm only allowed to give you contraception, not sort out your heavy menstrual bleeding. It's demoralising. It really is. So I think it's not only going to be a recruitment tool for staff, it's also going to be a workforce retention. We badly need that.
Absolutely. I just wanted to ask around whether that enthusiasm from ICBs has been matched by need. So are the enthusiastic ICBs the places where actually you're seeing the greatest need?
Well, actually, I would say yes, because I think then of the northeast and Cumbria, which have got some of the highest levels of deprivation. And they have embraced this really very, wholeheartedly, and was the first ICB, I believe, to set up 3 hubs and decided that they were going to prioritise this because they thought it was going to be so valuable.
And have the ICBs ring-fenced this funding? Has it been ring-fenced?
No. And I'll be quite honest, I think there were several. So if I go back a moment, if I may, when we set up the when we decided to ask every ICB to set up a hub, we also set up a group called the Network of Women's Health Champions. So we asked every ICB to send someone to a meeting, which we've had, I think it's 9 or 10 meetings now, usually monthly with a break over the summer. So it's been going for over a year now, and if I say to you that there isn't 36 or 42 people turn up, it's usually more like 90. So there's a lot of enthusiasm for it. And what some of them were telling me, sotto voce, was that no, they didn't think that the money was being used the right way because it hadn't been ring-fenced. And I think at that time there was a decision politically, which I can't influence, to not ring-fence anything apart from maternity funding.
Okay, thank you. Dr. Mann, you talked earlier about the importance of providing care that's sensitive to the local area. Are women's hubs a way of doing that, particularly around the cultural and religious sensitivity? And have you seen any good examples of it?
So I think there's lots of emerging sort of pockets of good practice in this. So first of all, I think just to sort of say something a bit more general than that, we have to remember this is a sort of transformation, and some ICBs were further down the line than others. So a lot of the emerging good practice that we're seeing around those kinds of things is the ones that we're already sort of starting to set up. So I think we can expect that there will be different paces of change. We are really encouraging areas to look at their local populations and really understand how they shape those services around that. And, for example, in more rural populations, there's more of a kind of mobile approach or more of a virtual approach. But I think the important thing is, we know in any development, the important thing is leadership. So we need to really make sure that there's leadership there, and then understanding health needs. And inequalities needs to absolutely be in there as a key, being able to demonstrate that actually we're impacting inequalities as well as impacting overall health. And at the end of the day, we need to be able to measure that. So we've done some initial work about, for example, we've seen that we've looked at HRT prescribing, for example, and there are massive inequalities in that. So that's a good way of local areas sort of shaping their services according to those differences that they're seeing. So use of data, leadership, having an inequalities strategy, and then having, the kind of workforce and the structures within that to make it work. And then I think, we've seen other programs. So, we saw the teenage pregnancy strategy that took that kind of approach. So we've learned, and I think that those are the ways that we need to sort of think about it more.
Thank you. An evaluation of the hub model found some shortcomings. As we expect with any pilot, we always want to see things to improve, including that they found that it was rare for women's hubs to offer multiple services. What were the barriers to that, and how do you think we could overcome that in the future?
Well, I think resource probably. As I was saying earlier, we didn't have a strict pro forma, when I think Sue was saying it, strict pro forma of setting out this is what you've got to do, because you're going to have different needs whether you're rural or urban or seaside deprived or whatever. So it wasn't going to be a prescriptive, you've got to have this, but I don't think any woman should be going to secondary care, going to a hospital for anything to do with her smear or a colposcopy, her periods, her contraception, her menopause, and I would say her urinary problems as well, at least in the first instance. So much can be done out in the community. And we could give you some examples of really innovative hub models that have done things very differently. So there's one in Croydon that I visited with Gillian Merron a couple of weeks ago that have reduced the number of women waiting for urogynecological incontinence surgery by 50% by providing physiotherapy and self-taught exercises in the community. There's a fantastic example in Tower Hamlets where they have designed a single point of access, so a virtual triage centre where senior people went through the referrals, and by then signposting them to the correct place, i.e. a hub or a diagnostic centre or secondary care, they got the number of referrals going into Whitechapel and Mile End Hospital down from 86% to 26%. Wow. Which is a massive, massive difference when you're thinking about the costs, the overall costs of sending someone for a procedure in the community and sending someone to secondary care. The economists will tell you what they put a figure on, and they are very, very different figures.
Thank you. Dr. Mann, problems with the existing commissioning structure in the NHS have been raised as a barrier to many of the women, the hub model, the women hub model. What do you think needs to change to improve this?
So interesting, because I was just talking about this yesterday, and we've got a policy research unit doing a whole study on what's actually currently happening in commissioning and how we can do it better. So really looking forward to hearing the output of that to make a sort of some recommendations. In NHS England, we've been developing some sort of commissioning support guidance for the system. So we're hoping to help the system to make decisions that will foster the development of this kind of service and do it well. The problems with commissioning, and I'm sure you're aware, are that different bodies commission different things. And so, for example, if we think about contraception, we think about IUD insertion and IUS insertion. The local authorities commission IUDs for contraception, and the ICBs commission IUDs for heavy bleeding, for example. So if you are not having your IUS for contraception, you're not eligible to be fitted by that service, and then you have to go to a secondary care service and sit on a waiting list. So hubs will facilitate that, but the commissioning structures need to make sure that they follow. So that's just one example. There are other commissioning bottlenecks that we know about, and in the end, this is all about collaboration. So it is about collaboration between all the different players to deliver to the same ends, and we need to work out we need to help ICBs to do that collaboratively. And while I'm on the topic of collaboration, none of this will happen unless primary and secondary care work together as well. So collaboration in terms of how you commission and contract services, but also getting the system to work effectively together and plan that pathway approach, rather than all of us sitting a little bit in our ivory towers and going like, well, I do this, and that's new, that's a change in culture. So it does take time, and that's why it's been difficult even for the system to have the conversations. So again, that's where I go back to leadership being absolutely essential, and then some kind of driver in sort of outcomes to say, well, how are you doing, and then supporting the system. So we will be going out to ICBs, and we will be working with them to look at how they're doing, what the barriers are, how we can support as well as we can.
Thank you. And in terms of talking about collaborative approaches, the mental and the physical side of this, we've already touched on the trauma that many women have faced. Do you think the hubs sufficiently provide mental health services or work with mental health providers in their areas?
We know that there's been an injection of more support in terms of the mental health system. So I think there's 8,500 extra mental health workers. What we need to do is connect the dots up better. So there are different areas of mental health that are being sort of reasonably well addressed. So there's self-referral to talking therapies, we've got perinatal mental health services, we've got maternal mental health services. So there are a number of things there. In terms of how do you make sure that all these things work together, and it's not just mental health, it's things like pain specialists, it's physios. So there's a multidisciplinary team. So the women aren't just seen as you've got this condition, but they're addressed as a sort of person. Weight management is another really, really important one. So learning how to, I guess, incentivize that connection is really difficult. At the moment, the system doesn't do that, but we need to kind of think about those. So those commissioning levers are important, and helping ICBs to determine how that pays and how that's more efficient. And that's that's complex, obviously, and it's locally determined.
I think it's a mindset change as well. I think instead of thinking, oh, I'm commissioning contraception or I'm commissioning cervical smear uptake, you're thinking, what does this woman need, and wrap the services around her. And that's going to require secondary care to get out of their territory and primary care to get out of their territory, and think about, well, what do we need for this woman and to make sure that she's able to access those things. Because going back again to my first point was that she's usually not ill when she's having these things. So to prevent her getting swift treatment so she can get on with her life again, her work or her unpaid caring or whatever, we need to actually pull this and understand what she needs. So rather than you going 5 different times to come and see me or somebody, one of my colleagues, you need to be able to go to one place and have it all done. So Sue made the comment about the IUS for contraception and the IUS for maternity, but while I'm putting in her IUS and I've got a speculum in and I can see the cervix, I'm not meant to be doing her smear because I'm in secondary care. We don't do smears there because it's somebody else commissioning those. So this is just not sensible.
Thank you. Samantha.
Thank you so much. I am finding this all really quite enlightening and fascinating and horrifying in equal measure in parts. I want to change the topic a little bit and move on to research into women's reproductive health, if I may. And I'll ask this of you, Dame Regan, if I may. To what extent is investment in women's reproductive health research sufficiently prioritised and funded?
Well, it isn't. Yeah. So, if you read the McKinsey report or the Deloitte report or the report that came out from NHS Confederation just 2 or 3 weeks ago, there's some very stark figures about how little money goes into reproductive health research. And there's all sorts of reasons for that. There's gender biases and not recognising what's needed. There's fear from pharma and from industry and tech that, okay, if we include women of reproductive age in these drug trials or these procedural trials, we'll be litigated against if something happens. There's a long history that has to be unpicked. But I think the most interesting thing about the McKinsey report, I thought, was this analysis that they did with a lot of pharma companies. And when you're exploring new research tools, they talk about assets. So an asset is a molecule that is it under investigation to see whether it can solve a problem. And the example that they did, which I think is very hard-hitting, is 1 in 10 women have endometriosis, and there are 25 molecule assets in the pipeline being investigated. 1 in 10 people globally have diabetes, and there are 584. So it's not, so there's exactly the same prevalence of this problem, but women's health has been thought to be, in quotes, a niche market, and that's the other narrative I think has to change. There's nothing niche about 51%. It's the majority, and so we have to change that.
Okay, and the next, it sort of leads me on to a bit of an extension to that question, and it's so incredibly broad, but I'll be fascinated by both of your responses to this, actually. actually, no, let me go back a step. I'll ask that separately because it is so broad. Just going back to the research, I feel like I'm asking a rhetorical question here, quite frankly, with the answer to the first question being no, there's not enough. But is enough research taking place to understand how different groups of women are affected by reproductive health conditions? So if we take not a lot, how much of that not a lot is then done in understanding how different women are affected by reproductive health conditions?
Well, I think there are things that there are disorders that affect women disproportionately. And if you actually add them all up, the things that affect women disproportionately, like rheumatoid arthritis, migraine, things like this, you'll find that over 50% of the research spend is just not getting anywhere near them. And we actually have to reset that dial completely because it's really important. So going again back to that McKinsey report, and Deloitte have also done one recently, what they've shown is that you have to bust a few myths. So number one is that women live longer than men, so they must be healthier. Wrong. They live longer than men, but they spend a disproportionately lengthier period in the later years in poor health. And the next myth is that women's using up health services are at the end of life, and that's not the case. It's not just menopausal women between the ages of 45 and 65 who, when they leave the workforce, create an economic problem, which is now being recognised, and employers are trying to do something about it. The reality is, if you look at the numbers, that a vast majority of those DALYs or disability-adjusted life years are in women from the ages of 20 to 45. So I can happily send you the report. It's very interesting. It's beautifully produced with fabulous infographics that you just remember the numbers because they've done it very cleverly.
Welcome, Matt. Thank you. So to both of you, but I'll come to you first if I may, Dr. Mann. The broad question, what would be your priority research area for women's reproductive health?
So I think so. Obviously, the role of the NHS in research is not actually commissioning the research. It's the, trying to identify areas, as you talk about, and then also equally as important, trying to support the sort of uptake of research and influencing the shape of it as it goes forward. I'm very keen to see us do more research around women's experiences. And so we have the reproductive health survey, and we know, just alluding to your point before, that actually the sample that we got was more educated women, more white women. There weren't very many older women included in it. So we know that we have got some information, but we've not got enough information on those particular groups. So I think doing something very user-focused in terms of experience would be really important. Narrowing it down to conditions is really difficult because there's a wealth of conditions, and often the things that come up are, we can influence the calls for research in terms of areas, but the decisions get made elsewhere. The other side of things is, making sure that we I alluded to that about using research, but there's a lot of implementation research. So implementation is a science. So, how do we best get research taken up in practice? So how can it actually be most useful? So the science is really, really important, new developments, innovation, all those things. But actually getting things into practice is really difficult, and we don't always do it as effectively. So actually conducting research on the implementation, which there's a whole big science around health services research, I think is also really important and under-addressed.
Yes, I can't really add much to that. I think that's absolutely it. Everyone's got their niche area, haven't they? I've always been interested in the repeated miscarriages and the immunology of pregnancy, but that compared to some of the other issues we've been discussing today, like menstrual health problems or pelvic pain, it's tiny, it's like that. So I think we've got to really think about what are the problems that really trouble women and stop them getting on with their day-to-day lives, stop them being able to go to work or finish their education or look after their families. And we've got to focus it on that. So I would say a lot more work on controlling menstrual problems, because that is just such a common problem. And very, very, very rarely there are only one or two groups in the UK who are doing meaningful work on this. Whereas there are lots and lots of organisations and universities want to look at the next drug for, say, ovarian cancer, which of course is very important. And if you know someone who's had ovarian cancer, yes, you'll be championing that. But the percentage of women that affects is very small. And I'm not in any way decrying work into cancers, but that's also driven by research and spending, because there's an enormous amount of money to be made by pharma out of cancer drugs. And so they tend to focus on those, but not on the ones, say, that are going to improve women's menstrual lives or provide them with a much better form of contraception.
Yeah. It feels like a massive, it just feels like a huge thing to unpick. And your expertise is kind of blowing my mind, so thank you so much again. Just coming back to what you were saying about using sort of period tracking tools, example, which has caused some fear, particularly when we've seen what's happened in America with the Roe v. Wade and people concerned about their data being sold so they can be identified for having had a termination when it's brought me to, and I premise this with, I'm the founder of Labour Women in Tech. I have done work with organisations that have got, and women in particular, who have founded femtech companies that want to help women, which is almost, the demand for it has been born off of the lack of services for women, for it taking up to 8 years for an endometriosis diagnosis and I've heard some people say, actually, it was me using this particular femtech product where I'm monitoring whatever it might be, that I've gone to the doctors and insisted there's something wrong with me, which in itself is a slight problem, because you've got to be digitally included, so you've not got to be from a poorer background where you can't perhaps afford these products, and the products themselves cost money, and you've got to know that they're out there. So with that in mind, that it's empowered some women, but then it's excluding others, what potential is there for the NHS to be using femtech to sort of improve awareness, diagnosis and treatment of reproductive health conditions in particular?
Somehow we've got to be able to sort through these femtech companies and only commission the ones who are altruistic.
Yeah.
Because, for example, the Flow founders, the Flow app.
Get me started, yeah.
I mean, they are billionaires, these two men. And they're selling, I don't know how they've got away with it, because they're selling their data.
Yeah.
Whereas there are other organisations that I've spoken to recently, because I'm interested in this, again, wearing my charity hat, and who are trying to do things for absolutely zero gain, because they want to actually improve lives.
Yeah.
But then, my daughters would say to you, Mum, that's not realistic. People don't do that.
But it is a minefield out there, isn't there? I mean, there are an absolute explosion of femtech apps, and I think that it's our job to help people navigate through them. So, we shouldn't sort of put off innovators, so I think it's really good, but there's some amazing apps and there's some lower quality apps, and trying to keep pace with that is really, really difficult. So how do you help women to reach good, accurate information and make decisions that are helpful for them, and find their way through the stuff that looks glossy but maybe isn't so good? So I think a few things. So one of the things that we've been supporting a funding call recently to try and get innovators to come forward with their proposals for femtech. So that's Small Business Research Innovation, SBRI, have put out a call, and we're about to we've had 200 applications, so we're about to decide which of those are the most promising, so that's really good. Some other things that NICE actually do that I didn't realise until I came to NHS England, but they do something called early value assessments. So they've been looking at all the menopause apps, of which there are very many, and trying to trawl their way through and actually evaluate the usefulness, the accuracy and so forth about them. So that will be something that will be published. So obviously it's really difficult to keep pace with that because there's constant innovation, but I think it's a start. And also I think we need to get better at producing our own information and digital information, and we need to start keeping pace. So, we've got online things. We could use the NHS app better and some YouTube sort of videos, but we actually need to get out into the space to really sort of understand that a little bit better, I think.
So, a slight extended question on this then. So, when it comes to coming up with innovative products for use by the NHS, you have got the greatest expertise within the NHS because you have got your clinicians and experts who, arguably, if they're encouraged to be entrepreneurial about this, and I know that there has been some resistance and some encouragement depending on who I've spoken to, do you think that would be a good thing for the NHS, that you are actually leveraging the expertise of people that understand these conditions and treating women, as well as perhaps having an interest in technology and being able to then almost be an entrepreneur that is a doctor as well?
I mean, I think keeping pace is really difficult, and obviously, you know, maintaining, you know, no conflict of interest there. So I think it's really important to be balanced and, you know, have a view and look at things objectively and make sure that the decisions that get taken are purely on the basis of improving health and care and information, and that's difficult. So you know, we've got people on the case. So the Health Innovation Networks have been doing a scan of looking at all the apps that are out there and trying to map them and trying to look at the usefulness. It is obviously a big job, so we can't do it alone. So it's just trying to find a process to look at the best ones coming forward and try and be aware of them, but have a sort of way of identifying the ones that are good and the ones that are less good. And I don't think we've quite cracked it. There are some things in place, and there's a whole part of NHS England that looks at what's in the pipeline, where the gaps are, what needs to be developed, where we should support innovation. So that's part of our Transformation Directorate, and they're doing a lot of work about trying to understand the landscape of what's going on and what's not going on, because, you know, you're only as good as the things that are produced, and then we actually don't produce things that people aren't interested in but might be very useful. So that's important to recognise as well.
Thank you very much. Thank you. Alex.
Thank you. Waiting times are particularly problematic, and waiting times for gynecological treatment have grown faster than any other specialty. Why is that, do you think, and what is being done to bring them down?
This is controlling our lives at the moment, isn't it? Looking at waiting lists. So I think there are lots of different drivers. One is that I think women are more aware, which I think is a good thing, that they need to go and ask for help. And I think that the commissioning and the reduced resourcing has meant that they're no longer able to access many of the things that I've talked about, saying that I don't think you should need to go to secondary care for those. They've not been able to get that locally, and that's why I think that the hub model that we are both pushing is going to resolve a lot of that. So if you actually look at the waiting lists, many of the women who are waiting on the gynecology waiting list, which is very large, are not going to have a procedure or an admission to a hospital. So my question is, well, why are they on this waiting list, and why can't they be sorted out nearer to home? So I think it's this pre-referral pathway that we've got to put the energy into, and that's sort of the left shift. So it's not quite going back to prevention, but it's actually making sure that when they have a problem, that problem doesn't get worse, and that they're sorted out locally in the community, and then you leave the people who need, for example, admission, invasive procedures or surgery on that waiting list.
Yes, it has been occupying us, and they are very large. There's 600,000, and they don't shift. But what we have seen is quite a lot of improved efficiencies within sort of secondary care. So there's been a lot of work with the Getting It Right First Time programme to try and look at how we can, you know, reduce length of hospital stays, doing less invasive procedures, how there's been a lot of support to the system from that team to go out and really sort of try and work out how to address the waiting list. But the rate of referral in is out of keeping with the pace that we can keep up with. And so, as Lesley said, you know, it's really important to think about how we can manage that bit of the pathway better, so the demand rather than the actual kind of productivity, for want of a better word. And so I think there's a lot of things, And as Lesley also said, understanding the drivers is important. And one thing that is sort of key in that is, firstly, people are waiting for diagnostic tests in secondary care. So they might see someone, wait for a diagnostic test, come back for another appointment, and then never require anything in hospital. So we've got the community diagnostic centres, I think there are around 167 now. So really thinking about how can we use those most effectively, but how can we join them up with the pathway so they're not just diagnosis, they're also diagnosis and treatment. Quite a lot of work going on there, because one reason that the waiting lists have gone up is there's been a massive increase in HRT. And when you start prescribing HRT, you start getting irregular bleeding. And when you start getting irregular bleeding, you start getting more investigations. Right. And then you put people on waiting lists, and then they need to have a hysteroscopy. So there's a new pathway for bleeding on HRT to be a little bit less sort of anxious about it and more able to get the right diagnoses, but manage that and only taking someone to investigation if they really need it. So that's one really simple approach that's happening. Another thing that's happening is developing some advice and guidance for GPs so that, and as Lesley mentioned, something like a single point of access, which will not only support appointments in the community, but also help GPs to manage people. So with people there, sort of providing really good detailed advice. So we've had advice and guidance for a long time, but making it more a sort of total triage where you can advise GPs, but then you can also direct. So if someone needs, so we talked about pessaries and incontinence, another thing. Those things are massively big problems, affect loads and loads of people, don't need to be in hospitals and are in hospitals at the moment. So we need pelvic physiotherapists, and we need people in the community who can change pessaries, so elderly women don't have to travel for miles. So those are some other simple things that we can do. We could go on a long time, couldn't we, on waiting lists? But
Thank you, Kirsty.
Thank you. Just to follow on from that, and I know we've touched on it already, but I wanted to ask specifically around endometriosis. I've got a constituent who came to me very distressed. She's been waiting over 18 months for treatment on that. I've got friends and family who have had to wait. I think they've been given about 70 weeks waiting time to get a laparoscopy to confirm the diagnosis. I just wanted to know what specifically is being done on those two areas. And apologies, I might have to leave before you finish your answers, but I just wanted to ask that question.
Well, I go back to what I started with, is that, if her painful, heavy periods have been sorted out a long time ago, she probably wouldn't have progressed to get endometriosis. And I would also say that you don't really need to have a diagnostic laparoscopy, because, fitting this individual with a Mirena coil and providing her with relief for both the pain and the heavy bleeding might be what she needs. And she could have that done in the community. And if it wasn't resolved by that, then she may need to go on and have a laparoscopy. But I think it comes back to the education points that you were saying in training, that we've got to get people to recognise we've got to get healthcare professionals to talk to women about, well, we're going to start this. It's not that I'm palming you off with a pill or a Mirena device, but let's see whether this gives you a bit of relief. And if it doesn't, then we will go on to the next step. And I think their patient-initiated follow-up is a really important thing, because if I tell you that, okay, well, I think we finished this, you tell me that your symptoms are sorted out, I'm going to discharge you, but if you need me again, you can contact this number or this email address. Then you probably won't need it, but many of the women who are sitting on waiting lists at the moment or on follow-up lists are there because they're so scared that it's taken them so long to get in there to be seen that they don't want to be discharged and have to go through that waiting again.
Yeah. But what about if they don't need a laparoscopy, like you said, but that's what they've been referred for? Is that because there might be a bit of a missing link in terms of the awareness or training or pathways, as you've suggested earlier, in terms of on the healthcare professional side? Yeah. Could that be the case? I think
that must be the case. That must account for some of them, not all of them. Yeah. But I would have to ask your friend or your family member, what has been tried. And if those things hadn't been tried, then I would say that those were options that she needs to pursue now.
Just a couple of points on that. So in general, if you release the kind of log jam of the system, then those people who do need laparoscopies won't be waiting so long. So that's a sort of general point about how we kind of free up and reduce those waiting times. Second thing to say is the longer people wait, the more complicated the surgery gets, and therefore the longer it takes and the longer people need to stay in. So if you start moving people upstream, which is very much the direction of travel, certainly with the 10-year plan, you know, treatment to prevention, secondary care to primary care and community, and actually that is what we need to do in women's health. So that's the other sort of really important thing.
Thank you. Alex?
Thank you. I think you've answered most of my next question, but do you think there's anything else that should be done that you haven't already mentioned to tackle waiting lists? And should there be a target for diagnosing certain conditions, such as endometriosis, to drive improvements? Is that something that would work, in your view?
Well, I mean, one of the things that I have a concern about in the data is that, you know, when the clock starts and when the clock stops is when you have a procedure. My metric is she better? And has she got back to day-to-day life? And so I think that's what the metric should be. But I think that's what we should really be pushing for, because I'm sorry that the one thing that seems to make people sit up and listen is not doing the right thing by women, but there is a financial drain on society if we don't. But if that's the game, then we're going to have to, you know, play it very well. And as I say, I think the McKinsey report and the NHS Confederation report that came out as well a couple of weeks ago have demonstrated that there is a massive loss to society and to people's well-being, both their physical and mental health, by not looking after women with these very common things during their reproductive and their post-reproductive years. And also I think in instilling in people that I'm the first generation of woman who's going to live probably longer post-reproductive than I was reproductive. And that wasn't the case for my granny. She was going to die relatively early. And as I said earlier, you know, we live longer, but we have a very much longer period of ill health. And also getting women to understand that the things that are going to really be troublesome for them later are not cancer. Cardiovascular disease and the complications of osteoporosis and frailty and dementia. Those are the three big killers. And yet we tend not to do very much about preventing them during their reproductive years and explaining to them how they can not avoid them but postpone them until a later stage in life, so that they can remain independent and not disabled by their problems.
Thank you. Rachel?
Yeah, I just wanted to come back on something that you talked about, the PIFU pathways, and whether you feel that sufficient research has been done in terms of how women access those, because are the timescales correct that have been set? There's a lot that we know about women not wanting to be a bother, so they've eventually got the treatment that they've been waiting so long for, and then they're told, well, don't come back, we're sort of discharging you now unless you tell us. That may impact on different classes, different ethnicities in a different way. You or I may be well able to sort of phone up and say, I don't think it's quite sorted out, but other people may not be. Has any research been done on that, and do you think those PIFU pathways will work for women?
It's not been my experience. My experience has been the opposite, that women have really welcomed it. I don't think, you don't want to sit in an outpatient clinic, do you, in the waiting room for hours and hours and hours, just because you've got nothing better to do. I'm sure you've got much better things to do. But my experience has not been that. When women have welcomed it and have been delighted that they've been pointed towards sources that they can get access back into the system if they need it.
Yes, and I would agree with that. I mean, I do think it needs to be offered too. So it's a good option. It's empowering for people, but it needs to be for the right person, as you're saying. And if you're speaking to someone who is unlikely to be able to activate it, I mean, one of the issues with this is giving the right information about how to come back through the system. In answer to your question, has it been evaluated? Not in terms of sort of satisfaction. So, you know, maybe that is something that we do need to look at. I think that it has a lot of potential as a good option because not only could it be empowering, but also we don't really know who needs follow-up and who doesn't. There's never been a sort of systematic, and who better than the person themselves to decide whether they could, provided it actually happens, that putting it back in people's hands, I think is welcome. But I absolutely take the caveat that, you've got to be quite confident to do that. So how it's delivered and how that communication pathway works is important.
Thank you. Natalie and then Christine.
Thank you. So since the strategy was implemented we're moving on to the next?
Yes.
Yeah, section 12, yeah, okay. So since the strategy was implemented in 2002, where have you seen the most progress and where is progress lacking?
I think it came in August 2022, not 2002, but I think the progress has been that women are much more aware about women's health. I often say when I'm introducing a session, well, if I'd invited you to come to this 3 years ago, you'd have said, well, what's that about, women's health? But now I think people are aware of it. It's been a great step forward that Sue Mann has been appointed because I see NHS England as the implementation arm for the policy, and that we can work together collaboratively to improve it. But progress is slow, but then I think changing hearts and minds is a slow business, isn't it? But it needs to be done, and it needs to be done well. So I think we will continue. I think the biggest likelihood of getting a success story and speeding things up is to scale up the women's health hubs, because I think they will be good for the workforce, and they'll be good for women, and they'll be good economically as well in terms of the returns on investment that one can make by actually organising, as I said earlier, wrapping services around women and not making women run around all the different services, which is always the most expensive way to do it.
Thank you. Was the Women's Health Strategy for England suitably ambitious, and what are the performance indicators which we can use to judge its impact so far?
Well, I think it was a very aspirational document. I mean, it didn't have an implementation plan, and that's what I think we're trying to do now, to implement it. So I think it was ambitious to say that no woman is going to experience these problems and not be able to access information. That is very different from where we started off. And I think, I do think that we've made quite a lot of progress, but as I often say to people I'm working with, I am one of the most impatient people I know, so I would like it to be a bit faster, but I understand that things take their time. But there is definitely, I think, a general move towards understanding that this is something that we've got to do as a society, and we've got to improve it, and that when you get it right for women, everybody benefits.
To Dr. Mann, thank you. A blood test's been authorised to help diagnose PCOS, but we understand it's not available via the NHS for this purpose. Should it be?
So I think the test you're probably referring to is something called the AMH test. So just sort of going a bit more general to begin with, because PCOS is a really, really important condition, and it's probably very under-recognised in the community, and it can cause a lot of distress. So it causes irregular periods, it can cause kind of unwanted hair growth, it can cause fertility issues. So we do need to get better at diagnosing it. So I suppose the question is, does this test offer additional benefits to diagnose and get people the treatment they need? And that is the sort of job of how we kind of, when a test comes online, just having a diagnostic test doesn't necessarily make it the right thing to do, and we need to just really understand what circumstances it's best used and how it can be helpful in terms of shaping treatment. So, for example, if someone comes to their doctor with irregular periods because they want to be pregnant or unwanted hair growth, both those conditions have lots of different things that could cause them. So we don't really just want to go straight to a diagnostic test. And when we look for polycystic ovaries, it's a combination, it's a syndrome. So we look at an ultrasound scan, we look at a blood test, we look at what people are actually complaining of. Does this test add value to what we already have? Probably it is, potentially a good test, and it may be that it will replace or it could be used as an alternative to ultrasound. So we've still got the other things that we need to look at to make a proper diagnosis of this syndrome. But Would it be useful as an adjunct? It's not completely clear. I'm not quite sure what difference it would make in my clinical practice, to be honest. I'm trying to sort of, and that's a very anecdotal thing to say, but I think the point I'm getting at is that all tests need to be sort of evaluated. Here we are, we've got a test. When would we use it? Who for? How? And how often? And actually that test is already available. So it's not a question of making it available. It's a test that's often used in a fertility setting. So it's not a new test. It's just using it in a different situation. So, it could be used, but I wouldn't say at this stage it's the right thing to do. But it's certainly evidence that it does have a link with the diagnosis of polycystic ovarian syndrome, for sure.
So if I just take it one step further, so AMH is a measure of your egg reserve, so your ovarian reserve, and there's a range, a normal range. And when you become menopausal, your egg reserve goes down to about 0 or a very, very low figure. And it's not really a diagnostic test for polycystic ovaries, it's just that women with polycystic ovaries tend to have very high levels, because what's being measured in their blood is the signals that these multiple follicles that they've got in their ovaries are sending out. So it's not saying this woman's got PCOS, it's saying she's got a high AMH, so possibly one of the explanations is either she's got a massive egg reserve or more likely that she's got polycystic ovaries. So I'm not sure that it's particularly helpful. It certainly doesn't diagnose the problem. So the diagnostic criteria are based on ultrasound and biochemical parameters, of which AMH is not one. But it is useful, AMH, when you're measuring, for example, some of the women I see who've had repeated pregnancy losses and they've got older as they do so. So it's important to know then what their AMH is, because there will be occasions when, if it's starting to drop, that you need to warn that woman that she needs to think about getting on with the fertility straight away, as opposed to wait for a couple of years. So it's a useful diagnostic test, but I think it's rather fictional, this idea that it's there for polycystic ovaries.
Thank you. So does the government need to change its approach to women's health?
Well, I think they have, haven't they? Well, I'm working under the illusion that they are. And I shall stick with my illusion, because that's the only way I can get up in the morning and carry on.
Wonderful. And I am absolutely thrilled that we're talking about women's reproductive health. And I really liked when you said that we need to think about what a woman needs and wrap our care around her. I absolutely love that. What it feels like there's a huge omission around is that there's no mention, I can't see anywhere, a mention of conceptions from rape, whether they're just conceptions, of which we have no idea how many there are, or whether it's up to 10 births every day that happen. I can't see anything anywhere on the internet about this happening in the UK. I specifically can't see it on the NHS website. There's nothing on the trauma of giving birth in these circumstances, the effect on the physical and mental health of the child and the mother. There's no guidance or acknowledgement that it happens. As far as I'm aware, there's no training for NHS professionals looking after these women, delivering these children, supporting these children when their mother has given birth in the most horrendous circumstances, and that's going to have lifelong impacts for them both. Should conceptions from rape be included as part of the women's health strategy?
Well, violence against women and girls is one of the 7 key themes. And I think that I often say it's one of the things that worries me most about the strategy, because this is such a ubiquitous problem. I've never met any other disorder that affects health, women's health, that has no socioeconomic, educational or class boundaries. It's highly prevalent, and the incidence is the same every country in the world. And I think sometimes the enormity of the problem makes people feel quite paralysed. Well, what can I do? And so we've got to, again, change hearts and minds by explaining, say, to every person in this room today, if you did one thing this week to call out some bad behaviour, or to say, oh, I don't think that's on, that's really not appropriate to be saying that or whatever, then we would all be putting a drop into the ocean. But it's a massive, massive problem, and this is not resolved by health, and it's not resolved by training people. I think most people who work in our field, in obstetrics and gynecology, are trained with trauma. They've got trauma-informed training for how to look after women We talked earlier about sensitive vaginal examinations, and then certainly there are, I've certainly been trained how to look after women who are going through labour, who've suffered from this particular problem. But we've got to make sure also that every other part of the government departments, the Home Office, DWP, the education sector, everyone's got to contribute to this problem, because it's a massive societal issue. I don't think the answer is just in health. It's important because obstetricians and gynecologists are second only to A&E doctors, accident and emergency doctors, see more, and they have more disclosures to them than any other group. So, if you are the survivor of an attack you're injured, you will either go to A&E or you will go and see an obstetrician and gynecologist, either because you're pregnant or because you're bleeding or you're frightened that you've got an infection or whatever. So we see a lot of it, but that's not the whole answer. We've got to do an awful lot more about training and educating, particularly young people.
You did mention earlier that Nagaman Chetty had asked you for something on the website and you delivered it. If you could consider delivering some advice around this as well on the NHS website, that would be really appreciated.
Do you think that most women would want to volunteer that information? So as a clinician who's talked to a lot of women who have been victims of sexual assault, many of them wouldn't want to disclose that information?
If there was, my question is around could there be guidance available to women that seek it? Right now, if you Googled, how do I tell my child that they were born as a result of rape, you would get results around countries very far away. There would be no acknowledgement anywhere on the internet, on the NHS website or beyond, that there are conceptions and births from rape in this country. So if you are a woman that has accepted that this happened to you and you are actively working out how you can square the circle of wishing your child didn't exist and having to raise it, then if you struggled in many, many ways, or if you were a child that realised that you were born as a result of your mother being hurt, there is nowhere in this country for you to go. And I think the NHS website, I understand what you're saying about that not being the full solution. Of course, there's more in other areas. But if we could provide some information for people searching for this advice when they are ready in their own time, in their own home, that would be really beneficial.
Okay. Well, if you'd like to email me, then we could talk about how we could go about that.
Thank you. And it would also be useful if there's any additional information that you could send to us on that specific point. That would be really useful. Thank you, Natalie. Christine, before I hand over to Christine, I wanted to say that I am aware that we have now gone slightly over. We only have 2 sections left of the questions. I think it's been really fascinating and very, very useful, particularly because we've come through to this report halfway through. So this is very useful for all of us on this committee. And I thank you very much for your time, but I'm going to hand over to Christine and then quickly to Catherine. Okay, thank you.
Thank you very much. To a previous answer, does the government need to change its approach to women's health? I can't speak for the government, but I think I can say quite conclusively that Parliament has. Since we had more women in Parliament, we've been more aware. And we have seen some very high-profile campaigns, Caroline Harris's campaign on the menopause, for example. But I wondered, are these coming too late in life? We're coming to them as adults, fully formed adults. What's your assessment, on the other hand, of the quality of education on women's reproductive health in schools? And what, if anything, needs to change to improve education there?
Well, you've probably been informed, I chaired a committee for the Department for Education last year, which was looking at the age appropriateness of sex education in schools. And I learned a lot about it, actually, because I thought I knew quite a bit, but well, you could always learn more. The issues, I think, are that historically, although this was mandated in 2020 as being part of the curriculum, what hasn't been mandated is the training for the staff to deliver it. And so what many teachers told me, because I went to talk to a lot of teachers about this, is that the teacher that wasn't in the staff room and the decision was made is the one that was given the sex, the RSHE part of the portfolio. So there may be people who've got no experience or, have had very little training. But I do passionately believe that if we were to teach girls and boys about periods and sex and space and privacy from a very early age, we would resolve many, many of these problems. I mean, if every girl came out of school understanding that she's going to have 12 periods a year for 40 years of her life probably, she would know then that her fertility is limited, and she wouldn't then be surprised when she can't get pregnant, and she would also know she's going to have a menopause. And she would also know then how it would be much, much better for her if she didn't have an unplanned pregnancy. And I'm sure you're aware that 45% of the 800,000 maternities in this country are unplanned. So they're not, I'm not saying they're all unwanted, but they are unplanned. And the abortion rate has gone up significantly in older women. So these are women who finish their families, and they tell me, because I have a big abortion clinic at St Mary's, that they're there because they can't access long-acting reversible contraception. So I think that we have a massive, massive need to really put sex education in schools right front and centre. And, you know, for example, the average age of menarche, of period starting, has now gone down to 10 years of age. So if you're not teaching the 8 and 9-year-olds, and you need to teach the boys and the girls about it, you're going to miss it. So again, wearing my charity hat, I've done quite a lot of school period workshops. Invariably there will be one young woman or young girl who will come up at the end of it and say, "Oh, miss, could I ask you something?" And then she tells you a story about her friend who woke up in the middle of the night saying that, you know, she thought she'd died because she was in pain and there was blood all over the bed. So an 11 or 12-year-old who doesn't know what's happening to her. So we've got to ensure that that we've actually taught them this at school, because they're not getting it from their parents, and they're getting stuff from social media which is inaccurate. And I think that we really do have an obligation to do this well, because they are our future. And if they're not prepared for what's going on, I think it's really very sad.
And I actually just can't emphasise how strongly I feel that it starts at school, and you know, adding really onto what Lesley says, which I agree with all of that, but I think also we need to arm our young people with critical thinking skills, because as you were saying, you know, there's so much information out there. If they're unable to understand their bodies and how to name the parts of their bodies and how to talk about things without feeling embarrassed, we're not going to really start sort of tackling the stigma that comes later in life and the difficulty with finding the things that they need. And they also need to know where to go and when to go there. So we need to give them kind of routes in to getting the help they need, but knowing when that is. So, yeah, so really important.
Thank you very much. I wanted just to drill down that wee bit. Specifically, we've talked a lot about misunderstanding endometriosis and how period pain can lead to endometriosis and getting these things quickly. So at what age do you think children should start to be taught about the actual health conditions, as opposed to reproduction itself, the actual health conditions that can affect girls and women?
Well, again, I go back to the point that if we instilled in every young person the fact that women are going to have these periods, and that it's not normal to be in a lot of pain and to have a hot water bottle all the time or take days off school, I don't think we would have such a problem. I'm not trying to be simplistic, but it's that understanding of this is a normal thing, but you don't have to suffer in silence, that I think that's a really, really important step forward. And I mean, I've been to some schools where they've had the most amazing education, and that they talk to 5-year-olds not about sex or, as you were saying, rape, but they talk about, well, hang on, why have you taken Matthew's teddy away from him? Matthew's upset now. Can you see he's crying? Why have you done that? Because you've invaded his space and you've taken it. And I think there's lots and lots of ways that one can instill in very young children the sort of ethos and morals that we're talking about, without having to. Because I think there was great concern in Parliament that we were going to be sexually explicit to 5- and 6-year-olds, but that's not the point at all. It was age appropriateness of the information they're given, so that they are not shocked and frightened by things that are happening to them, and they are prepared for them.
Is it fair to say from everything you've said that you feel it's just as important that boys are part of these lessons as girls?
No, I mean, there's no point if you have them separately. So, and you know, as I say, with wellbeing of women, we've gone to several schools. They said, we haven't got any boys in our school. I said, well, find some, bring some in, but they need to be part of it. So what we usually do is have a workshop on this is the reproductive cycle, and this is what is happening, and this is why it is, and then bring in the boys at the myth-busting session at the end. And they tell us, the young men tell us, that they want to know, because they've got mums and sisters, and both of them want to be caring about it. And also the young girls tell us that they want the boys to be there, because otherwise it's still a taboo subject.
Absolutely.
Thank you.
Thank you very much, Christine. David, quickly.
Just very quickly on that, actually, taboo. And I was reading that many women will not tell their employer the real reason why they're not able to come in work when they're suffering from a particularly challenging period. And as an employer, I still have a business that somebody else is running for me now, but I'm an employer here in Parliament. That makes me feel incredibly uncomfortable. What more can we do to raise awareness of women's health issues with employers so that maybe they're more sympathetic? Because clearly this reluctance to talk to the employer comes from experience of employers maybe going, well, it's just your period, why do you need time off work? Is there more that we can do here to educate and raise awareness with employers?
Yes, and the DWP have had a whole programme of work going on about providing information for employers to do this in a much more sensitive and understanding way. Again, I think the only way it's going to get real traction is by emphasising the loss economically if we have women who can't go to work or can't get on with their caring roles. And I think that needs to be emphasised. And as I said, I'll forward you this report, which I think is really, really helpful, as is the NHS Confederation one as well, which demonstrates that you can, as an employer, you will benefit enormously from investing in some sympathetic counselling or getting the HR people or occupational health or someone to talk to this woman and to help her feel supported so that she doesn't quit her job or start to do just 2 days a week, which will benefit you as well. And I suppose the only other thing I could say is that, you've got women in your lives and you just want them to have the best opportunities, don't you? And I'm sure that most of the men that are in the room here today or in this Parliament would feel the same way. I think sometimes personalising it to, well, what would you do if this was your daughter or your wife, is the only way to get the message over.
Thank you, Dame Lesley. I would probably push back on that and say that they shouldn't just care because they have a daughter or a wife. They should care because this is part of society.
Oh, yes.
But by any means, I guess we'll take it if it's going to mean progress. Thank you. Catherine.
Thank you. Thank you so much. This has been so fascinating. I'm sure we could all go on for hours longer, but I will try not to keep you both too long. But you've been absolutely brilliant witnesses. Thank you so much. So women's reproductive health is a taboo subject for many, isn't it? And it's at every life stage. And I guess I'm quite I'm a middle class privileged woman, but I came to need a total hysterectomy a few years ago now, and I found myself, people saying to me, "Oh, are you going to tell people what you've been in hospital for?" And I was like, "Well, yeah, it's my womb. It's nothing to be ashamed of. I'm having it removed." But I have to say, when I left hospital, as I was leaving hospital, one of the nurses said, "Oh, do you want a patch?" And I was like, "Oh, what for?" "Oh, because you're probably going to now experience the menopause straight away." And even though I'm an intelligent woman and I've been to university and I was CEO of a women's equality charity at the time, I just kind of went, "Oh, I'll be okay." I didn't really understand that the menopause would most definitely impact me, and I certainly did hit a brick wall a few weeks later, and obviously now I've got the right treatment and everything. But in terms of the apps and the femtech, my apps were my friends. I happened to have some friends who were a little bit older than me who were going through the menopause, who were like, "Oh my God, I can't believe you've left hospital without anything, and you need support and you need help." And they helped me through it massively. I mean, without my girlfriends, I don't know where I'd be right now. I probably wouldn't be sitting here, that's for sure, because I would, like many women, have given up work because I was really struggling. So anyway, how can we challenge the stigma that prevents many women and girls seeking support? Should I start with you, Dr. Mann?
So that experience absolutely shouldn't happen and is shameful. So there's something about, and we know, obviously the menopause has had a lot of traction over recent years, hasn't it? And we all know much more about it. But actually, a particular group of women who experience very sudden menopause, when, like you did, you had a sort of surgical cause, but also some women go through it early. And I think that's a group of women that need to have a sort of particular care and particular information. So that just sort of to recognise that, and that's about the kind of care that you had and the warning and the explanation. So that should be different. But I think you're right. I mean, it starts, much earlier on, and people are talking much more about menopause. So, we have a lot of influencers out in the system, and we're talking a lot more about it. So that's a good thing. But, really going back to that conversation we just had about RSHE, that actually stigma is about what you grow up with and culture and what boys know and think. So, there's a long time to do that work, but we really do need to keep those conversations going about, there's a reproductive life course here. You start your periods, you have a reproductive life, you make choices in that time, and then you have a menopause. And these are normal things, and boys and girls need to understand that. And as Lesley said earlier, women are living roughly half their lives in the menopause, so it's not a sort of fringe area. It's really, really sort of essential. So I think tackling stigma at every level, having the conversations, and you alluded to the workplace, making it easier for women to come forward. And I'm glad you've said what you said, because it's not always straightforward, is it, for people to share those things. And the more that we do it when we're in those positions, the more it will encourage. I think people need to stand up and be counted. And I think that's also really helpful. If people see that around them, they feel more comfortable with it.
Would you like to add anything?
No, I don't think so. I think that sums it up beautifully.
And what action should the new government take to ensure women with reproductive health conditions get the support and understanding they need to stay at work? And I think we've kind of already covered that to some degree. It's about the economy, stupid, isn't it? It's about showing, in a way,
or prioritise women's health hubs, and you will fast track it.
Yeah, great. And do either of you think there should be a public health awareness campaign on women's reproductive health?
I think we've got one, haven't we now? I think that I'm not wishing to sound complacent about it, but I think people are a lot more aware of it. And that doesn't mean we should be, sort of stop trying, but I think we need to carry on with that. I also think, going back to a point earlier about, you were talking about influencers, Sue, and then someone mentioned about social media, we've got to make sure that we're communicating these in the way that the recipients we want to reach, access communication. So there's not much point sending out sheets of A4 or long turgid documents in a PDF to people who are only going to access their information on social media or on LinkedIn, or perhaps not LinkedIn, but Instagram or whatever. So one of my New Year resolutions for next year is going to be, I must get rid of my fear of social media. Because I think people of my generation are a bit wary of it. And then you hear about people who've been bullied and, cancelled or whatever, when they've used it. But I think we've got to recognise that if we want the next couple of generations down of young girls and boys to understand, what these things are, then we've got to communicate with them in the way that they receive and absorb their information. And it ain't on pieces of paper.
Yeah, there is incredible campaigners out there. I know, may I abuse the chair one moment, Sarah? There's an amazing group in Wales of two young women called, and they do Instagram Love Your Period, and they're absolutely brilliant, and they have just spread the word so much in schools and become ambassadors, and it's incredible what they've done.
Well, Nigat Arif posts something every day. And she gets her three sons. She's got three sons, and they do all the video footage for her, and then they post it.
Thank you very much, Catherine, and thank you very much to our witnesses. Dame Lesley, if I'm going to make one recommendation to you, don't go on X as your first chance of social media. There are other providers available.
I do have an account, but it's very, very badly used.
I just want to say thank you very much on behalf of the whole committee for the time that both of you have given today, and your experience and your in-depth answers. We're very grateful. Thank you, everybody. That brings proceedings to a close. Order.